Hello friends, the topic is working length determination. Now friends, this topic is a small topic and despite that, a lot of MCQs come from this topic. So in that sense, this topic becomes you can say a high yield, high impact topic, right? Less content is there and more MCQs. So always good to do these topics very well because your strike rate improves when you know of getting your correct questions right and getting more number of attempts. Always more fruitful to spend more time on such topics, right? So working length determination. First of all, let us just have a very brief overview. When is it that we are trying to determine the working length when we are doing our root canal treatment or our endodontic procedure? We've selected the case for root canal treatment. We've given local anesthesia, isolated the tooth with rubber dam, done our access cavity preparation, removed the pulp from the pulp chamber, located the root canal orifices with our DG16. Now we are in a position to go and determine our working length, right? So that is the basic overview of what all we are supposed to do prior to determining the working length. So let us start with this basic concept. The chapter is working length determination. What all have we done before determining the working length, friends? We've done our case selection. Right? We've given local anesthesia, rubber dam, isolation is done. Right? Then we have done our access cavity prep. We have removed the pulp from the pulp chamber. Right? Then we have located canal location of canal orifice with our endodontic probe or explorer, that is with DG16. Always remember, friends, locate the orifice of your root canal with your DG16, not your root canal files. All right. So we are in a position wherein now we are going to determine as to what depth we are supposed to do our cleaning and shaping and subsequent obturation procedures, right? So that's my tooth. Right? I've done my access opening. That's my canal. All right. Now, friends, very important to note here the important terminology. Before we go any further, the important terminology. What is the working length? It is the length from a reproducible or repeatable coronal reference point to the length inside the root canal at which we are going to terminate our cleaning, shaping and obturation procedures. So working length determination or working length determination definition is that length from the coronal reference point to the point up to which the cleaning, shaping and obturation shall be done. Right? That is the definition of working length. Right? The next important terminology is the anatomic apex or the morphologic apex of a tooth. See, if you have a tooth in your hand, an extracted tooth in your hand, imagine this is an extracted tooth in your hand. The tip of the root would be the anatomic apex. Simple. So that would be the anatomic or morphologic apex. Right? Next important point, friends, is what is the radiographic apex? Now, when we're doing a root canal treatment, we're trying to save the tooth, right? There is no question that the tooth is going to be in our hands. So for all practical purposes, for an endodontist, for a dentist who's doing a root canal treatment procedure, anatomic and morphologic apex is not important. That's number one. So don't be confused with this, right? Then we have the radiographic apex. Now, the radiographic apex is the tip of the root. Simple. Geographically, the tip of the root. We're not interested till now in the apical foramen, apical constriction, major diameter, minor diameter, cemento-dentinal junction. We have not reached that point as yet in our discussion. That was very clear, right from the very basic. So, the radiographic apex is simply the tip of the root. Is the tip of the root as seen on the X-ray film. So that's the end or the tip or the end of the root as seen on the X-ray film. Right, friends? So in this case, what is going to be the radiographic apex here? Simple. This is the radiographic apex level. Why? Because this is my tip of the root. Tip of the root. So this would be my radiographic apex. This obviously is important. This obviously is important in understanding the concept of working length. Now, the next important concept is the exit. The exit of my root canal. Now, the root canal exits onto the root surface via a foramen known as the apical foramen. Now, this apical foramen may or may not coincide with the radiographic apex. That's number 1 point. So, next important terminology is the apical foramen. Apical foramen is the foramen through which the root canal exits. The root canal exits onto the external root surface. The root canal exits onto the external root surface. Now, this apical foramen may or may not coincide with the radiographic apex. Means the root canal might exit on a lateral root surface, that is mesial, distal, labial or lingual or palatal root surface at some distance short of the radiographic apex. And unfortunately, that is more common. In a study done in Japan, it was shown that up to 80%, 68 to 80% of the cases, the apical foramen did not exit the root canal at the level of the radiographic apex. So the important point here is that the apical foramen may or may not, the apical foramen may or may not exit at the level of the radiographic apex. In fact, it is unfortunately more common for the apical foramen to be located eccentrically on the lateral root surface and not coincide with the tip. Right? If it coincides with the tip, then it is relatively easier to determine the working length. But if it is not coinciding with the tip, if it is curving and if it is exiting the root surface on a lateral root surface, labial, lingual, mesial or distal, then it becomes tougher to determine your working length. Now, in general, up to what distance short of the radiographic apex, does the apical foramen take its exit? It is up to 3 millimeters. That's an important MCQ, right? So if I'm to draw this diagram here, this is my tooth, this is my radiographic apex, this is my root canal, and if it is exiting on a lateral root surface here, then up to 3 mm short of the radiographic apex, my apical foramen may be located. Now, be that as it may, irrespective, now the important point here is this. This is where most of us make mistakes. Irrespective of whether the apical foramen coincides with the radiographic apex or is exiting short of the radiographic apex, the apical constriction is almost always further short of the apical foramen by about 0.5 to 1 mm. So the apical constriction is usually 0.5 millimeters to 1 millimeters short of the apical foramen, friends. Right? Now, what does this mean? Basically, if I am to enlarge this area, this apical anatomy, let us just enlarge this area of the apical anatomy here, this portion, right? And let us see this in detail. So, that's my apical part of my root canal system. Right? The narrowest part of my root canal system, narrowest cross section is the apical constriction, and then for a distance of about 0.5 to 1 mm, there is this divergence, and then at the end of this divergence, the root canal exits through its foramen. So this is the apical foramen. This is the narrowest part of the root canal system. So that is the apical constriction. And the apical constriction is short of the apical foramen by 0.5 to 1 millimeter, friends. Right? And this is what is important here. That your working length is not to the apical foramen. It is up to the level of the apical constriction. Why? Because that is the narrowest part of the narrowest cross section of the root canal. So when we are basically imparting a wound, that would create the smallest possible wound to the human tissue when we terminate our cleaning and shaping procedures at the apical constriction. That's number 1 point. Number 2, normally it is the apical constriction which more or less, not every time, but more or less coincides with the cemento-dentinal junction. What is that? It is the point at which dentine ends and cementum starts. So in other words, the cementum is not just located on the external surface of the root. It goes inside the canal up to a distance of 0.5 to 1 mm. That is up to the apical constriction, usually. Right? And the second important point is that we know that the dental pulp, the dentine pulp complex is one tissue, isn't it? Developmentally, dentine pulp complex is one tissue. So at the level of the cemento-dentinal junction, the pulp tissue ends. And when we're doing root canal treatment, we are only interested in cleaning the pulp canal space. If you move beyond the apical constriction, you are actually in the PDL space. Now, I don't want to, tear my apical constriction, increase my, lose out on the natural constriction that I have, because that would actually provide a nice, positive, snug fitting of my Gatta-Parcha obturation system when I obturate the root canal system. I want to stay restricted to the histological dentine pulp complex when I'm cleaning my root canal system, number 1. Number 2, I want to create, or you can say maintain, that natural constriction that is there inside the root canal system, so that I get a nice resistance form to overfilling. I do not overfill my Gatta-Parcha and sealer so that it does not extrude into the periapical spaces. Right? So that is the reason why my working length would be till the apical constriction, which is the narrowest cross-sectional diameter of my natural root canal anatomy. Right, friends? So working length is always short, at least short of the apical foramen by about 0.5 mm. And because the apical foramen may or may not coincide with the radiographic apex, so when you actually see your preoperative X-ray, for a normal, you can say safety, as a safety distance, you should always reduce 1 millimeter from the radiographic apex. Right? You can interpret that as, say, 0.5 mm for about the eccentricity of your apical foramen, which may not coincide with the radiographic apex, and further 0.5 mm for the short of length apical constriction from the apical foramen. This also does not necessarily ensure that you have restricted yourself to the apical constriction, but yes, you have to take that chance. Obviously, the X-ray knowledge and the determination of working length by the X-ray has to be supplemented by the determination of working length by the electronic apex locator as well. That is why we say, and a very important MCQ, that the best way to determine the working length is a combination of radiograph plus electronic apex locator. That's your very important MCQ. And this is the reason why nobody can really see the apical constriction and the apical foramen on the X-ray. You just kind of using your knowledge, using your tactile feedback, using the apical periodontal sensitivity response from the patient, and trying to gauge as to where the apical constriction ends when I'm in that area between that 0.5 millimeter to 1 millimeter area between my apical foramen and my apical constriction, and so on. So with experience, with your tactile feedback, you're trying to get a precise idea of where to stop. Right, friends? So friends, let us just see the important possible image-based questions which you can get from your standard textbook. These images are a combination of images taken from your Ingle and Cohen. Both are your standard textbooks. Even your Grossman primarily takes, images from these two or textbooks, or you can say, or whatever important images are from Grossman, we also incorporate them in our presentations. Anyways, this concept that we were discussing here, the first scenario is the fortunate scenario, as you can see, wherein the exit of the root canal, that's your apical foramen, is coinciding with the radiographic apex. As I said, anatomic or morphologic apex does not make any sense to us because we don't have our tooth in our hands, right? So for all practical purposes, the tip of the root for us is the tip that is seen on the X-ray. If the X-ray is distorted, well, that's our bad luck. But for all practical purposes, the tip of the root or the apex of the tooth is the radiographic apex for us. Now, if our apical foramen exit, that is the exit of our root canal system, is coinciding with the tip of the root on the X-ray, then it's very simple, right? You simply subtract 0.5 to 1 mm from the entire length of your tooth, that is from your coronal reference point to your apex of the tooth. You simply subtract 0.5 to 1 mm to reach your working length. However, if it is lateral, exiting laterally, right here, then then the situation becomes complex. Here the apical foramen is exiting on the side wall of the root surface. So you have to, on the X-ray, measure this length as to how much short is the exit of the main apical foramen, right? So for instance, if this distance is 3 mm, right? So that would be the distance. So in that sense, from your reference point, you will have to reduce 3 millimeters in terms of the total length of the tooth. That is, if from the incisal reference point to the tip of the root, if the length is say 20 millimeters, then your apical foramen itself is, if 3 mm short, then it's 17 mm, but that is the distance to the apical foramen. My working length would be further 0.5 mm short, at least, if not 1 mm. Right? So in this case, my working length would become 16.5. So that is where you have to do, you can say you have to do adjustments at 2 steps, right? So you need to understand that it is always better to take your file to full length and see just where it is peeping outside the root canal system into the periapical tissue, right? If you can just take your file just beyond the apical foramen, say 0.5 to 1 mm into the periapical tissue, you will know exactly as to where my, exit is onto the lateral root surface, right? So that is a very, this is a nice diagram which is very clearly showing these two situations. And unfortunately, the second situation is more common, right? Then the other situation that we have been discussing is this one, right? That is the apical constriction, which is the narrowest cross-sectional diameter at which our working length should be established. This is known as the apical seat or the apical matrix, right? Because this would give me a nice, nice seat against which I can pack my gatta parcha. All the more important for warm vertical compaction techniques wherein I want to ensure that my gatta parcha does not exit the root canal system and extrude into the periapical tissues, right? That's why apical constriction is the point wherein I'm going to terminate my cleaning, shaping and obturation procedures. As you can see, since this is the narrowest cross section, this is also known as the minor diameter. So apical constriction, minor diameter are one and the same. They're synonymous for all practical purposes, right? Then you see this divergence, which I showed in the hand diagram also, right? This divergence is like this, you can say, the paintings that we used to do when we were kids, right? The sun rising from in between the two walls inclines of the mountain, right? And that is why, isn't it? This appearance looks like that, you can say, half the rising sun in between the mountains that we used to do. So that is why this shape is also known as the morning glory. This shape is also known to resemble the morning glory? That's again another MCQ, friends. Please, we can all note that down. So from the apical constriction to the apical foramen, this shape is known as the morning glory appearance. The other important thing is that B represents the relatively larger diameter, right, of the apical foramen. So that is also known as the major diameter. So again, next MCQ, apical foramen is synonymous with the term major diameter. Apical constriction is synonymous with the term minor diameter. Between the major diameter and the minor diameter, the shape of the root canal system resembles that of morning glory, right? So all these are important MCQs. Let us just write these down. Apical constriction, minor diameter, that's your MCQ. Apical foramen, major diameter, that's your MCQ. And the root canal in between the apical constriction and the apical foramen is in the shape of the morning glory sun. Morning glory sun. Right, friends? So that is another important MCQ. Then what is the next terminology? So what are the terminologies which are important for MCQs that we've done? We've done the anatomic apex or the morphologic apex. We've done radiographic apex. We've done apical constriction. We've done minor diameter, apical foramen or the major diameter, morning glory appearance. Right. Then what is the next important point? The next important point is Wien's modifications. So what happens is that in general, we are supposed to keep our working length 0.5 to 1 mm short of the apical foramen, of the length till the apical foramen, right? However, so that's a normal situation where there is no, on the X-ray, there is no root resorption nor there is bone resorption. However, what if in a situation there is root resorption and bone resorption? Now those situations are known as Wien's modifications. Right, friends? So as you can see, friends, in this diagram, as we said, that the safety margin from the radiographic apex is 1 mm. Why? Because the apical foramen can be eccentric, right? Not necessarily in every situation it would be 2 or 3 mm. So let us just say that it's just 0.5 to 1 mm. And further, 0.5 mm short is the apical constriction from the apical foramen. So in general, from our coronal reference point right up to the radiographic apex, if 20 mm is the length, then 19 mm is our working length. Simple. That also can be, we can be beyond the apical constriction, but according to the radiographic technique, let us just keep it at 1 mm short. That is more or less acceptable. So in a situation where there is no bone resorption, there is no root resorption, Wien says go with this standard. That's 1 mm short. That was proposed by Dr. Engel himself. Now what if, as you can see in the middle situation, if bone resorption is there, right, that means there is periapical inflammation, there is bone resorption. Then normally what happens is, if there is bone resorption, there is some level of root resorption also, which is not apparent on the radiograph. Now what if there is root resorption? There is root resorption, then you have to further reduce your working length by a more value of 0.5 mm. So in all, reduce by 1.5 mm in order to ensure that your cleaning, shaping and your obturation material is not in your periapical tissues. What if radiographically also you can see both bone resorption and root resorption? If on the radiograph you are able to see root resorption, then please understand that there is severe root resorption that is there, right? So in that case, you have to keep your safety margin even higher. So further reduce by 1 mm from the existing 1 mm criteria. So you reduce a total of 2 mm. So please memorize this. Wien's modification, W-E-I-N-E. Dr. Wien was a great endodontist. His textbook also is very famous. Wien's recommendations for determining working length based on the radiographic technique only, right? So it's just a modification. It's not an independent technique, right? So modification of the classic X-ray technique, classic recommendations given by Dr. Engel in certain added situations of number 1, bone resorption, number 2, bone plus root resorption. So add 0.5 mm and 1 mm respectively. So 1 plus 0.5 mm, 1.5 mm, and 1 plus 1, 2 mm, right? So that would be the safety margin. So you have to increase your safety margin in such situations. So these are important MCQs. Let us just again write these down. These are very volatile things, right, friends? So Wien's modification, no bone resorption and no root resorption. Simply reduce by 1 mm, right? Bone resorption present but no root resorption. Then reach your working length by reducing the total length by 1.5 millimeter. Bone resorption is also there, plus root resorption is also there, reduced by 2 millimeter. Each and every point is an important MCQ. Right, friends? Now let us look at, this was a basic overview, right? Now let us look at the various methods by which we can actually determine the working length, right? So various methods of determining the working length, right, friends? The number 1 method, obviously most commonly used, is your radiographic method. Now within the radiographic method, the most standard and the best considered is obviously Dr. Engel's method, which is commonly referred to as the Engel's method. Then of course we've just discussed the Wien's modifications over the Engel's method, Wien's modifications. Then we have the Grossman's formula. That also we must know, the Grossman's method or the Grossman's formula, right, friends? These are the 3 primary, you can say, radiographic methods that we must know. Then we have the second method, that is the electronic determination of the working length, right? So that would be the electronic method. In which we shall discuss the apex locators. Then the third method is tactile method. Tactile method is when we feel the resistance in the file as we move closer to the apical seat or the apical matrix or the apical third, simply the apical third of the root canal. An experienced operator would say that he can feel the constriction in the canal, and that is where you would say that by the tactile feedback I can estimate that I've reached the working length, or in other words, I've reached somewhere near the apical constriction. That's the tactile method. Then we have the periodontal sensitivity method. Simple is that when the file reaches the PDL, the patient responds by raising his hand, saying that I have pain. So that's periodontal sensitivity method. And lastly, we have the paper point method. And what is the rationale? Again, when you reach the PDL, the paper point gets wet by the tissue fluids. Now, obviously, a paper point you can use only when you've completely extirpated the pulp and the canal is relatively dry, right? So you're confident that you've extirpated the pulp, or if it's a non-vital tooth with abscess, you've drained out the abscess, the canal is dry. And then you take your paper point beyond what you think, what you estimated was the working length, right? And then you can fathom as to whether you've reached the PDL space or not. Now, no one method of working length determination is foolproof, right? So what do? Should we use, in order to reach that one unique value right up, which signifies the apical constriction, should we use all the 5 methods? Are using all the 5 methods recommended? No. The question that would come and the answer would be that the best way of determining the working length, in which no special situation is mentioned, in general, for any tooth, in general, is a combination of radiographic method and electronic method. That's number one. The number 2 MCQ that comes, and which came for the first time about 4 years back in AIMS, is for the determination of working length of an open apex case, of an open apex tooth or an immature apex tooth, which is the best method. Then there is one single answer, and that's the paper point method. So let us just note these first of all. Before discussing in detail each method, let us note the most important thing for us, that is solving MCQs, right? So let us write this down. Best method to determine working length in general, no special situation is mentioned, is combination of radiographic method and electronic apex locator. Now, within the radiographic method, if someone asks you, obviously Ingalls method is the best, right? Then the second important question that comes is, that's your MCQ, best method to determine working length in open apex, which can also be mentioned as an immature apex tooth or an immature tooth, is the paper point method. Right, friends? All right, now let us go back and discuss each and every important method in detail. So in the radiographic method, we start with the Ingalls method, friends. What are the prerequisites, number one, of correctly determining the working length by the Ingalls method? Obviously, you should have a preoperative, undistorted, clear, good quality IOPA X-ray, number one. Number two, you should have a basic working knowledge of the lengths of all the teeth in general. That's number two. You should obviously be having a divider and a ruler or an endo gauge so as to check, see the length of the tooth on the X-ray, right? Now with that, when you have the X-ray, you expose the X-ray, preferably with a paralleling cone technique, so that your X-ray does not show any foreshortening or elongation. You have the X-ray in front of you. You take your metallic ruler and you see the complete length of the tooth, right? For instance, on the X-ray film, the length of the tooth is 20 millimeters. Then, as a safety margin, you reduce 1 millimeter. So your provisional working length is 19 mm. Simple. Now with your endodontic file or reamer and your silicone rubber stopper set at 19 millimeters, you insert that file inside the root canal and shoot another X-ray. Now, if on the X-ray, when you develop that X-ray, if the distance between the tip of the file and the tip of the root is exactly 1 millimeter, that's your final working length. If it is not, right? If the distance is more, or if the file is beyond the apex, that means your pre-op X-ray was distorted, right? So let us just look at this step by step, right? I have, again, I'll draw the tooth. I'll also show this in the diagram as shown in Ingle. I have the diagram, right? But we'll first develop this concept. This is a tough one. Students normally have, doubts in interpreting this method. So let us just develop this concept with the help of hand diagrams, and then we'll see, for the image-based question, we'll see the reference picture from the textbook. So that's your tooth, friends. Taken a nice pre-op X-ray. As far as I'm concerned, I'm very confident that this X-ray is undistorted. This is my reference point. This is my tooth. This is my radiographic apex. Now let this length be 20 millimeters. I keep my file at exactly 19 millimeters, right? So that's my file. It goes inside my root canal, right? And I've set my rubber stopper exactly at 19 millimeters. So now see. This is my root canal, right, friends? This is my root. All right. Now, if this distance was exactly from the apex of the tooth, if this distance was exactly 1 mm, right, friends? Then that means 19 plus 1, 20, I'm perfect. My pre-op X-ray was good. 1 mm short, that's my final working length. What if this distance is 1.5 mm? Right? This is on the radiograph, right? That means there's a discrepancy of 0.5 mm. Means there's something wrong with my pre-operative X-ray. Now, this distance is 19 mm for sure. Why? Because this is the distance that I've measured physically outside the oral cavity, right? I've taken my ruler or my endo gauge or my endo block and I've measured it physically with my own hand. So this distance is 19 mm. So what do I do? That means my determination of my tooth length was not correct initially because my X-ray was distorted. So now my tooth length becomes what? Instead of 20 mm, it becomes 19 plus 1.5 mm. That means 20.5 mm. And the final working length would be 20.5 mm minus 1 mm, which is 19.5 mm. Right? So this is a method in which we sequentially reduce the error. There is no guarantee that there is no error in this also. But the level of error is very less. Because if this X-ray is also distorted, the second X-ray is also distorted, the distortion is only happening for this 1.5 mm. This 19 mm is definitely correct because that is the length that I measured physically. You understand? So I have reduced my level of error. Right? The other situation could have been that this 19 mm file was beyond the apex. So what if it was beyond the apex by 0.5 mm? So I will reduce the length. So that means 19 minus 0.5 mm, that is 18.5 mm would be my tooth length now, and 18.5 mm minus 1 mm, that is 17.5 mm would be my final working length. Right? So I hope this is clear. This is slightly tough to understand, you can keep rewinding and just keep marking what I'm saying, and that's the greatness of having recordings, right? You can keep reviewing them, rewinding them, and seeing them again. However, the good news is that I'm also going to discuss the exact original diagram given in Ingle, so we're going to have another revision right away. So see this original diagram from Ingle, friends. See this. So that's my pre-operative X-ray, right? I have taken that's my pre-operative X-ray. See, and from my incisal reference point to the tip of the radiographic apex, that's the complete length of the tooth. Radiographically, I've measured, and that has come out to be how much? 23 mm. So my tentative or my provisional working length would be 23 mm minus 1 mm, that's 22 mm. Now I measure my file at 22 mm and then I insert it inside the root canal, right? So if this is not very clear, let me just put a highlighter here. I think that would make our life easier. So you can see here, exact 22 mm, I put my file inside, right? Now, and then I take another X-ray. Now, what if the remaining distance was exactly 1 mm? That means this would have been my final working length. However, here there is an additional 0.5 mm. That means the 22 mm is short of the radiographic apex by 1.5 mm. So now my length of the tooth instead of 23 mm becomes 22 mm plus 1.5, that's 23.5. And my working length becomes 23.5 minus 1, that's 22.5. So my final working length becomes 22.5 mm, friends. Right? Now this is a great method still used today. It's a more than 45, 50-year-old method given by Dr. Ingle. And just see the simple common sense with which sequentially has reduced the error on the X-ray, isn't it? And given us this wonderful method of determining the working length by the X-ray, right? The second method is the Wien's method, which we have already discussed, friends. So Ingle's method is done. Wien's method we've done. Then we have the Grossman's formula. Again, very interesting. First of all, we'll see the formula and then I'll tell you the logic behind it. Grossman's formula is based on ratios. And friends, ratios never lie. I'll tell you how. So we have the formula as, what do we want to determine? We want to determine the actual working length, right? Based on X-rays. So let us have a ratio in which we say that working length divided by the length of the instrument. Right? As seen on the radiograph, as seen on the X-ray, right? So if I have an X-ray in which I have checked my length of the tooth as 23 mm, so my radiographic working length would be 22 mm, right? So this would be my radiographic working length. So radiographic working length divided by the radiographic length of the instrument. Now what does this mean? This basically means that if I have an X-ray which is distorted, right, friends? So on that distorted X-ray, my numerator would also be distorted by the same amount as my denominator. So this ratio would not vary. You understand? So when we're talking of ratios, even if I have a distorted image, the numerator and the denominator would be distorted by the same value. So the ratio would be the same. So the ratio of radiographic working length divided by the radiographic length of the instrument would be equal to the actual working length divided by the actual length of instrument. actual length of instrument I know. For instance, on the X-ray, I saw the, I determined the working length to be, say, 22 mm, right? So I would set my actual length of the instrument to 22 mm, right? And shoot an X-ray. Now that X-ray is distorted, right? So according to that distorted X-ray, there would be a working length value, which I'll note down here. There would be, on the X-ray, I would measure the length of the instrument. That would be the radiographic length of the instrument. Actual length of the instrument I know, because that is what I have measured with my hands. So my actual working length would be, this implies that my actual working length would be the actual length of the instrument multiplied by radiographic working length divided by radiographic length of the instrument. Right, friends? This is based on the fact that ratios would be the same. So actual working length divided by the actual length of the instrument would be equal to the radiographic working length divided by the radiographic length of the instrument. Right? And that would give me, so when I know the 3 values out of 4, I would take a cross product and I would get the value of actual working length. So that's your Grossman's formula. This is the way with this logic, I don't need to memorize it, right? Obviously, in the stress of the examination, it's always better to memorize things, but you should know, just in case there's a short circuit in the examination because of stress, you're not able to recall, then you can actually derive the formula by common sense and your knowledge, right? So that's the way of doing this. Now, before moving on to the electronic method, friends, that's a long topic in itself. Let us see the tactile method. Tactile method is simple. When the clinician says that I can feel the constriction. Again, as a single method, as one single method of determining the working length, obviously not recommended, right? You can have multiple constrictions in the root canal. You can have a calcification. You can have narrowing of the canal due to certain other reasons like calcification. Then would you stop there? Like 5 mm short of the apex? No, you will not. Then periodontal sensitivity method, again, as an independent method, not recommended. See, these are all supplementary methods. You can increase your data collection. You can increase your, you can say precision of determining the working length by doing minor changes based on these. But you cannot rely on them. Why? You can have a patient may be hypersensitive, right? Even normal, normal pressure, the pain would say, oh, I have a lot of pain. Anxious patient, right? So not a good method. Paper point method, yeah. Paper point method is the method of choice in cases of open apex and immature teeth, right? Because in those cases, they say that the level of there is no apical constriction, right? The apex is not formed. So there is no apical foramen, there is no apical constriction, right? So electronic apex locators also won't work well. Radiographic method also is very arbitrary there. So paper point method becomes the most important method for open apex cases. Now, friends, let us talk about the other very important aspect of working length determination. That's your electronic method of working length determination. That's in general known as the apex locators, right? So the apex locators, which represent the electronic method of working length determination, friends. Now, friends, first of all, we have to talk about the principle on which it is based. Now, in general, irrespective of whatever advancements in apex locators has taken place in the previous 20-25 years, the principle is basically the same. That is, that when we generate an electric circuit, we create an electric circuit between the periodontal ligament, number 1, and the oral mucosa. There is a standard or a static value of electrical resistance that is generated in that electrical circuit. And this was determined way back in 1942 in Japan by a worker known as Suzuki. And then obviously his work was carried on forward by Tsunada in the 50s and 60s. And what they basically found out was that irrespective of whether you're testing humans or you're testing other animals like dogs and cats, if I create an electric circuit between the periodontal ligament and the oral mucosa, and the resistance, the electrical resistance of that circuit would be the same, that would be 6.5 kilo ohm. So if this is my tooth, this is my canal, and there is a file inside my canal, right? Which is going right up to the PDL. That's my PDL, right? If I attach an electrode, obviously that electrode, see the file is the one which is conforming to the shape of the canal and it's going right deep inside the canal up to the apical foramen, right? That's the periodontal tissues, right? Beyond the apical constriction, you have the periodontal tissues, isn't it? I get that. So that would actually act as an electrode. So if I connect a metallic electrode to this file, I connect a metallic electrode to this file, right friends? And there is this electricity generator panel, which is battery operated or electricity operated, whatever. And there is another electrode coming from this, which is say in contact with the patient. Either the patient is holding it in his hand, or there is a metal electrode which is in contact with the labial mucosa. Whatever. The electric circuit has to be complete, right? So on one end, it is connected to the file or the reamer, which has gone deep inside the root canal to just beyond the apical constriction, right? And the other electrode is in contact with the, for example, the buccal mucosa. So this is a cross section of the oral cavity. That's my buccal mucosa, that's my tooth. So this electrode is in contact with the buccal mucosa. I'll just highlight this for clarity. So this is electrode 1, contact with buccal mucosa. That's my electrode 2, which is in contact with the file. The electric circuit that is generated will have a static value of electrical resistance that is 6.5 kilo ohm, right? And that is where I set my auditory signal or my visual signal or both on my display screen of my power generator of my apex locator, that when this value is reached, 6.5 kilo ohm value is reached, that is when it starts to beep or shows a signal. Either it's an auditory signal, that depends on the circuit that I make. So when it starts beeping, that means I've just gone beyond the apical constriction, somewhere in the region between the apical constriction near the apical foramen. I'm somewhere in the PDL, right? And I get the signal, and at that length of the instrument would be somewhere near the working length, right? I will obviously have to reduce about 0.5 to 1 mm, isn't it? Because it's beyond the apical constriction. It's gone into the PDL. That's another very important MCQ. We'll discuss that later. That would be the last question of this topic, very important topic that we'll discuss. Over a period, so that's the basic principle, right? Now, over a period of years, in order to enhance the accuracy of the apex locators, people have tried and tested various methods. Like initially, they would use a direct current and they would get an electrical resistance value of 6.5 kilo ohm. They thought that, it's good enough, but you have your canal have to be, ideally dry. If there is some pus, abscess, tissue fluid, blood, hypochlorite, saline inside the canal, it starts giving false readings. The electric circuit gets completed prematurely, and you get that beep signifying that 6.5 kilo ohm resistance has reached, right? And the electric current had started, at that value. So you get false readings. So people started, employing alternating current at a particular frequency. Then they thought that, that is also not very, you can say, accurate. So then they started using multiple frequencies. They would see the impedance value and the capacitance values as a difference of two frequencies, as a ratio. Then in modern generations of apex locators, they would use multiple frequencies, more than two, like 5 or 6 frequencies, or they would also incorporate other algorithms like getting multiple values of impedances at a particular frequency and then calculating the root mean square value of those multiple values and reaching one particular value and claiming that our apex locator is better than the others. So all these permutations and combinations have been employed, right? So from our perspective, this is the basic principle, and let us see the various generations of apex locators which have come up. So the first generation of apex locators is actually based on this basic principle only, understandably so. That's the most primitive, so it would be based on what the experiments were done back in 1942. So the first generation of apex locators is based on direct current, and you all know in an electric circuit of direct current, the resistance to direct current is obviously known as resistance only. Resistance to alternating current is known as impedance. So when you're using direct current, these apex locators are also known as resistance based apex locators, and the classic example of the first generation would be the Sono Explorer, right? That is your MCQ. Then we have the second generation apex locators. So let us just write this down. MCQ number 1 here would be that they're also known as resistance based apex locators. MCQ number 2 is they use direct current. MCQ number 3 is the example, and that's your Sono Explorer. Right, friends? Then we have the second generation. In order to improve the accuracy, instead of direct current, people started using alternating current. And the resistance to alternating current is, instead of resistance, it's known as impedance. So because of that, the second generation apex locators are also known as impedance based apex locators. That's your MCQ. Or it uses alternating current, that's again your MCQ, and your examples would form the third MCQ. So second generation would be further modifications of Sono Explorer. I hope the examiner does not, give you the option of Sono Explorer and tell you and asks you whether it is first generation or second generation, because what happened was that certain modifications of Sono Explorer, they don't have any unique name. They are also classified as second generation. So hopefully the examiner does not use this fault line and this controversy and try to put a question. Still, if this simply mentions Sono Explorer and you have first generation as an option, then I would suggest you go for first generation. Anyways, apart from that, we have Apex Finder, Endo Analyzer, Digi Pex, Exact A-Pex, Foramatron 4, and Pio. Would I recommend you to memorize all these examples? It's not practically possible. I would suggest memorize at least Foramatron 4, right? Apex Finder, and specifically they ask that modifications or newer generations of Sono Explorer. This we should know. And then we have the third generation. What is that now? Now, the common thing between second and third generation is that this is also based on alternating current, but not at one particular value of alternating current. This is based on alternating two different types of alternating currents. One at one frequency, the other at other frequency. Right? So you have third generation apex locators which are working at two different frequencies, that means two alternating currents, right? You would get one impedance value and another impedance value, right? So we get two impedance values for the two alternating current frequency that we are using, right? Based on the difference, that is impedance at frequency 1 minus the impedance at frequency 2. That is one type of third generation apex locators, which is based on difference. The other type of apex locator, third generation apex locator, is based on ratio of these two impedances at these two frequencies. So impedance value at frequency 1, impedance value at frequency 2. See, when you know the impedance, you can also calculate the capacitance also. So capacitance at frequency 1 and capacitance at frequency 2, right? Irrespective of whether we are trying to measure the difference or the ratio, we are basically using a comparative method. So this is also known as comparative impedance based apex locators. So that's your MCQ. Third generation apex locators are also known as comparative impedance based apex locators. That's your important MCQ. Then the other important point here is that, friends, when you reach the apical constriction, right, the current which is at a lower frequency will have a higher impedance. The current which is at a higher frequency will have a lower impedance. And this difference will be the maximum at the apical constriction, right? And this is the basis for the setting of this apex locator. Now, if it is a difference, it would be comparative impedance would be based on the difference. If it's ratio, this comparative impedance would be based on the ratios. Now, classically, the gold standard of apex locators, with which all other apex locators are in general compared, is the root ZX. Now, first important point, root ZX is a third generation apex locator. It is based on comparative impedance, right? So it's a third generation. It's based on comparative impedance. And the third important point is, within comparative impedance, between the difference and the ratio, it utilizes the ratio method. That's your next important MCQ. So root ZX utilizes the ratio method or the division method to determine the working length. And next important point, it is relatively unaffected by the presence of fluids inside the canal. Again, because whatever difference in the capacitance values of the numerator and denominator that fluid would be making would be cancelled out in the numerator and denominator, isn't it? So therefore, if the canal is dry, then also it's giving you a nice accurate value. If the canal is wet with any fluid like blood or sodium hypochlorite or abscess or pus, then also it will give, the manufacturer says that it will give you a good accurate value. Although in general, a practical tip is that your canals should be relatively dry, irrespective of whatever advanced apex locators you are using, right? Next important point with respect to the root ZX is the two frequencies that are used are 8 kilohertz and 0.4 kilohertz. 8 kilohertz and 0.4 kilohertz. Since root ZX is the most commonly used, and not necessarily most commonly, in general it's considered as the most widely accepted, the gold standard with which all other apex locators, even the newer generation apex locators, are compared with, because the accuracy is very high. So there is no harm in trying to memorize certain more details of root ZX. Third generation comparative impedance utilizes ratio method. The two different frequencies of alternating current are 8 kilohertz and 0.4 kilohertz. The other examples of the third generation are the first third generation that was developed was Index, and it is marketed. This was in North America, and in the Europe and Asia, the same Index is marketed as APIT, right? Then the other third generation Apex locator is Neosono Ultima EZ, Neosono Ultima EZ. Then you have Just 2 or Justy 2. Then you have Apex Finder AFA. Apex Finder AFA stands for All Fluids Allowed. All Fluids Allowed. So these are some of the examples of third generation Apex locators, friends. Again, I would suggest you must know at least definitely the Root ZX. That is the third generation Apex locators. I don't know because of what reason, but some people do confuse it with fourth generation. No, Root ZX is third generation, no doubt about it. Then there is no harm in memorizing this Apex Finder, All Fluids Allowed, and the fact that the first third generation was Index, that was developed in the USA. And it is marketed as APIT in Europe and Asia. You can at least memorize these three. Then we have the fourth generation. Now, in terms of understanding the fourth, fifth, and sixth generation, friends, no need to go into greater detail. Just understand that they are, number one, they are using alternating currents. They are also using multiple frequencies. Some of them are using more frequencies, like 5 or 6 frequencies, right? Some of them are using them at the same time. Some of them are using each one at one particular time and getting impedances values for multiple repeated impedances values, right? They would use one frequency at one time and they would check the impedance value at least 5 to 6 times. And then in order to increase their accuracy, they would take out a mean, like a root mean square value of all those impedances values at one particular frequency and say that this is my final impedance value for this particular frequency. Then they would use the other frequency, then the third frequency, fourth, fifth, and so on. Now, the point is that the idea is that the fourth, fifth, and sixth are just, you can say, additions and modifications to the basic third generation philosophy. Third generation philosophy was the one which actually changed the way Apex locators were manufactured, in which they were using, number one, alternating current at different frequencies. Now you're just adding algorithms. You're just adding more frequencies or more values at one particular frequency and claiming that our Apex locator is better than the others. Right? That's it. You don't have to go into details of what frequency and so on and so forth. It is good to memorize at least 1 or 2 examples of each. So fourth generation would be Apex 4. This is easy to remember. Fifth generation is Joypex 5. Sixth generation is Apex 6. And it is also known as adaptive Apex locator. No harm in memorizing this. Right, friends? Next, what are the other uses of Apex locators? Since it is basically determining the PDL, so you can actually determine external root resorptions, internal root resorption. When it starts beeping, basically, see, Apex locator is a device. It does not have artificial intelligence. It basically tells you that the PDL is reached. So the PDL is reached in a vertical root fracture. It will tell you, it will start beeping. So other uses of Apex locators. So basically it is what? Detecting the PDL. So it can be used to diagnose a vertical root fracture, a perforation, which can be due to an iatrogenic perforation. That means you have done a perforation while doing axis opening or BMP. It can be a resorptive perforation. Right? Then it can diagnose external root resorption. It can diagnose internal root resorption and so on. Right? It can diagnose root fractures. So if you get that beep prematurely, then you can suspect these things. Is there a root fracture? because radiographically the apex locator is beeping, say 6 mm short of the radiographic apex, right? So these are the other uses of apex locators. This can come as an MCQ. Then the next important point, a very important question, a very confusing one, which came about 2 years back in AIMS, was that the zero reading. So if this is my display of my apex locator, right friends, and this is 0, and this is say 0.5, 1, 1.5, 2 mm short, right? So this basically tells you the advancing file. The file is advancing from the coronal to the apical part of the root canal. Now what does the zero reading on the display screen of the apex locator signify? That was the question. Does it signify the apical constriction? Does it signify the apical foramen? And some other options were there, but these were the two most important and confusing options. See friends, till the apical constriction, the electric circuit will not be really completed because it is surrounded by insulative dentine and cementum. Only when the file moves beyond the apical constriction and into the PDL space, that is somewhere close to the apical foramen, then only it starts to beep, right? So despite the fact that some manufacturers will say there are apex locators so accurate that it will determine the apical constriction, the zero reading of the apex locator, the best answer here is that it would be somewhere near the apical foramen. That means the zero reading will be where? When it is beyond the apical constriction and at the, see, the distance between the apical constriction and apical foramen is hardly 0.5 to 1 mm. So if we consider it 0.5 mm, so imagine your apex, your file is beyond the apical constriction by 0.3, 0.4, 0.5 mm, right? So that means for all practical purposes, it is nearer to the apical foramen than anything else. So the zero reading of an apex locator tells you that your major diameter or your apical foramen is reached, right? And from the zero reading, then you have to, now this is a practical tip, when you're doing your patient, from the zero reading as a safety value, reduce about 1 millimeter, just like what Engel did in his radiographic method. That would be your somewhere near your apical constriction, or slightly short of that, that's okay. Right, friends?